Our speaker this afternoon is Dr. Emery Brown. Dr. Brown is a professor of computational neuroscience at MIT, a professor of anesthesiology at Harvard, and a practicing anesthesiologist at Massachusetts General Hospital. Let's welcome Dr. Brown to our summer school.
Great, thanks a lot, Boris. You guys can hear me okay, right? Is that project okay? Okay, good. So I'm going to talk about anesthesia. Surprise, surprise. So these are the funding sources that we've had the good fortune to have from NIH and from my institutes at MIT as well as at Mass General Hospital. And so this is the outline I'm going to follow. I'm going to first give you a clinical look at what anesthesia looks like. And then I'll talk specifically about loss of consciousness under propofol. I'll say something about the other anesthetics as well. I want to show you how the response to anesthesia changes as the brain ages. And then I want to get to some ideas of, to the extent that we have some understanding of what the brain is doing, or how the drugs are affecting the brain, showing that we can build control systems to control it more precisely than we do now. And then in addition, turning the brain back on after anesthesia, as opposed to just letting drugs wear off and letting it come back passively. I'll explain the implication of that when I get to that. But here are the main points that I want to make. Under anesthesia, the brain is not turned off. I don't know what concept you have of anesthesia now, but it's not turned off. It's actually quite dynamic. I'm going to show you that in just a second. And we think that one of the primary ways in which the drugs are acting is it takes the extracellular currents and actually hijacks them and controls how neurons spike. And by controlling how the neurons spike with these highly structured oscillations, it makes it difficult for the various parts of the brain to communicate. I'll show you that in a second also. And so the good thing is these are very strong signals. They're not weak at all. You don't have to squint to see them. And they change very systematically with the drug class, the dose of the drug, and patient age. And I won't show you this, but also it changes very, very dramatically with health. So if you have a young person who's 20s or 30s has COVID, you'll see just slow oscillations. When they get better, you'll see their alpha oscillations basically come back. So they're affected by a number of things, the oscillations are. And I'll show you what I said, the closed loop control is very, very feasible. And then I want to give you this sense that this is also not only a way to develop a process or procedures so that people can have surgery, but it's also a way of studying the brain. All right, so what is general anesthesia? So it's a drug-induced reversible state that consists of antinociception, meaning you're not processing pain information, you're unconscious, you're amnestic, you're not moving around while the surgeons are operating, and you maintain physiological control. All right. So reversible, we bring you into the state with drugs, and we let the drugs wear off, and you come out. So what do we actually do? I mean, how do we actually carry this out? Well, we have this process which is called balanced anesthesia, balanced neural anesthesia. And so to start off with, you would give someone like a bolus of propofol, and that rapidly makes them unconscious. I'm going to show you that in just a second. Makes them unconscious. And then you have to maintain the state of unconsciousness. So you do that by having someone breathe and inhale gas, such as sevoflurane, isoflurane, or desflurane. And those drugs are ethers. We still use ether, basically. In fact, they're the most used anesthetics in the United States. Or you could run an infusion of propofol. And then at the same time, to control pain, you might administer opioids, ketamine, or magnesium, other drugs which control the pain circuits. And then so the person's paralyzed or immobile, we give muscle relaxants, and we reverse those basically at the end of the case. So you can see there's a whole slew of drugs that we administer. We don't administer something specifically for amnesia, because if you're profoundly unconscious or the brain is sufficiently shut off, you will be amnestic, all right? But if you look at these categories, you see how the inhaled drugs are in each category? I'm referring to the ethers. So it's no surprise that they were the ones that were first discovered as total anesthetics. So you can just give them alone, and you get pretty much all these conditions. They're not perfect, but that's the way it's done. And what's been found is that if you use small doses of each of the different drugs, you get most of the good effects and fewer of the side effects. And And then we use, medications to maintain hemodynamic stability or, as essentially needed. This is what's called sort of balanced general anesthesia. So just for a simple case, just like a hernia repair, you'll get at least 10 drugs, just as a balance. So it's a real pharmacopoeia. So let me just show you this. So in our ORs, we have EEG. You can put 2 EEG leads, 4 frontal leads on all the patients so you can watch the EEG. I use the EEG with all my cases. And this is a woman who's about 60 years old. She's going to have thyroid surgery. She weighs about 80 kilograms. I'm going to give her 150 milligrams of propofol, extremely standard dose of propofol. And we're going to watch what happens to her EEG. And this is in real time. It's not edited or anything. So the 4 leads, it's going to get noisy here in a second. And it gets noisy because when you inject propofol into a small vein like the one on the back of my head, it burns like crazy. So she's doing this. It's going to get really noisy. And that's actually going to be good pedagogically because you're going to see the moment that the drugs take over their effect. It's getting really noisy still. Because she's tensing up. But another 7 or 8 seconds here. But watch right here. These beta oscillations, watch them form. You're starting to lose consciousness. They get deeper, slow oscillations, low frequency. They get even deeper. She's out right here. She became unconscious. Now it's going to go flat. And then burst. And then flash. She's profoundly unconscious. She's also stopped breathing, so we have to take over ventilation for her right at this point. So what did I just show you? So this is her EEG when she's awake. So low amplitude, high frequency oscillations, gamma oscillations, beta oscillations, the sort of standard cognitive rhythms that we all talk about. And then what I was showing you here was a sedative state here, where she all of a sudden had these highly regular sort of beta oscillations. So if I wanted to anesthetize her so that she could have like a colonoscopy or something, then what I would do is I would just titrate the drugs and just hold her right in that state there. She'd be arousable. She could respond to me and what have you. She may not remember what happened, but she could respond to me. But what you saw next was she went right down from there. She skipped over D. We'll come back to that. She went into E and saw these large slow oscillations. So from an anesthetic standpoint, anytime you see slow oscillations, think that one component of it is taking away brainstem activity. And I could actually show you that clinically. It's too bad. I have a video of it, a video I made a few years back, but I don't have the permissions to actually show it anymore. But at the time when the slow oscillations come on, the eye is fixed in the midline. The control of the eyes is actually a brainstem phenomenon. So you can actually see the moment that the drug has its effect in the brainstem. It's affecting other parts of the brain also. I'm just saying a part of this is the brainstem. And in addition, another key indication that it's acting the brainstem is the person stops breathing. Because remember, the respiratory centers are in the lower part, or in the medulla, the upper medulla and lower part of the pons. And then what we saw was she went into burst suppression. So very profound state of brain inactivation. We're going to talk more about it towards the end, talking about controlling burst suppression. You see this in hypothermia, in patients who are in like traumatic coma, or children have this unfortunate disorder called early infantile encephalopathy, and where their brains are born highly underdeveloped. And as a consequence, they're just in burst suppression pretty much all the time. It's not compatible with life for more than 12 to 16 months. And between the bursts, she's actually isoelectric. And I didn't show you this state. This is the state we're going to talk about the most. See how it has 2 components? It has a slow oscillation and it has a higher frequency 10 hertz oscillation. This is the classic signature of propofol for like a young person. And paradox excitation, I'm just going to skip over. But I just want to show you get one general idea here. It's gestalt. High frequency, low amplitude here for these much larger rhythms that are basically highly coordinated and highly structured. So this is the anesthetized brain, basically. That's what the brain under anesthesia basically looks like. And then these oscillations will change with the drug class. We'll see a little bit of that in just a second. So just to give you another perspective of it, one of the things that we promoted is not just looking at the raw EEG, but looking at the spectrogram at the same time. So you see the spectral content, you can actually see where the oscillations are. And so this is a young woman I took care of a few years back. She's having a small procedure. So right here, I'm giving her a bolus of propofol. And they're the slow oscillation, just like in the case that I showed you a second ago. And actually, you can see all this over here, this noise. This is movement. You can see the same sort of thing. As soon as the drugs took effect, all the movement artifact went away. You can see this beautiful 10 hertz oscillation here, and then a slow delta oscillation, something between about 0.1 and about 4 hertz. So this is about 10 hertz here. You can actually see that up here in the trace. You can see the higher frequency oscillation, which is about 10 hertz, and then a lower frequency slow oscillation. Okay. Oh, very much so. I'll show you that in just a second. Yeah, very much so. So the sedative state for ketamine looks entirely different from the sedative state for propofol, or the sedative state for dexmedetomidine. So let me just, so then right here, so I started infusion. As I maintain the infusion, I keep her in this 10 hertz oscillation, slow delta oscillation here. I turn the infusion off, like let's say about right over here. The oscillations break up and she wakes up basically over here. Right, so this just gives you some sense. We'll talk about the spectrograms quite a bit here. So these are my colleagues I've done this work with. Patrick Burton at MGH, Shanung Cheng, former postdoc, who's now at WashU, Nancy Gopel, whom you all probably know is very well mathematician, Ahmad Eskandar, neurosurgeon, now down at Einstein, Eric Pierce at MGH, Laura Lewis, anesthesiologist at MGH, Laura Lewis at Boston University, Sid Cash, who's a neurologist at MGH. So I've shown you there's a temporal dynamic. I want to show you there's a really cool spatial dynamic. And so this was first worked out back in the late 70s by two anesthesia researchers at the Mayo Clinic, John Mitchenfeld and John Tinker. And they showed this in monkeys. So when the monkeys were losing consciousness, they had full head EEG. This alpha oscillation I just showed you starts in the back, moves to the front. It concentrates in the front of the head and stays there concentrating in the front of the head while the animals were unconscious. And then it moves backwards, right? And the animals come to, right? And the same thing happens in humans. And so we actually done a lot of studies on volunteers. People volunteered, let us anesthetize them. And so this is a volunteer here. And just one more little bit of physiology, which you may remember. If you close your eyes like this, and you put EEG in the occipital regions, you'll get an alpha oscillation. 10 hertz oscillation, it's called the eyes closed alpha oscillation. Pretty much everybody has it. It's very strong. Maybe about 5 to 10% of people don't. It gets a little weaker as we get older, but it's very robust. And so that's what I'm showing you here. So this is the 44 of 64 leads that I had on this one patient, who was one of my volunteer subjects. And so like up here, and I'm showing you the spectrogram at each of the 44 locations. So this is the front of the head over here, left ear over here, right ear over here. And here are those two occipital leads back here. So the two occipital leads, he's lying there with his eyes closed like this, and he's got a very robust 10 hertz oscillation. All right, so we're going to watch that oscillation. I'm going to increase the dose of propofol. You see where it says baseline up there. It's going to go up across 5 levels. And I see this oscillation move from the front, move from the back, concentrate in the front. And as we turn the drug level down, it's going to move backwards as it comes back. Let me just play this here. So it's still baseline. So the drug is starting, which says level 1. And watch how it breaks up here in the back. You can see it's starting to appear in the front. Now it's over the center of the head's right here. From there forward, you have the alpha oscillation and the slow oscillation. And it's not even at the deepest level yet. So now we get up to 5. That's the deepest level. It's gone in the back. Now watch, as we turn the drug back, allow it to back. See, it disappears in the front and reappears back here in the back. And the patient comes to, right? So the point that I'm making is there's a temporal dynamic, but there's also a very strong spatial dynamic across the brain too. No surprise, but sort of saying the obvious. So what can I tell you about this from a mechanistic standpoint? So propofol works by binding to GABA A receptors, so the inhibitory neurons throughout the brain. And it goes everywhere. It's very lipid soluble. If you actually feel it, it feels real greasy. It's white, it feels greasy. And so anywhere that it can basically get into fat tissue, get everywhere. So it works in the cortex up here with the interneurons. It also works, let's say, down here in the brainstem, and also it's not shown here, but also the thalamus. So those are like the main inhibitory centers, if you would, in the brain. All right, so I can draw these sorts of diagrams, and we did that like about 10, 12 years ago. You go to the OR, you give someone propofol, and you maintain an infusion. Particularly a young person, this is the pattern you're going to see. So, and then I just showed you this 10 hertz oscillation concentrating in the front of the head. And there's one thing which I didn't tell you about it, is that it's very coherent. So in other words, if you do just something naive, measure the correlation at the alpha frequency between two sites in the front of the head when the alpha oscillation is there, the coherence is around 0.8, 0.9. Or do something a little bit more sophisticated. You take like the global coherence. So you take the cross-spectral matrix, factorize it, take the ratio of the first eigenvalue to the rest. That ratio is about 0.8 or 0.9. There's one very strong direction in which this is pointing when the person is unconscious under propofol. This is just propofol now for the moment. So what's happening there? So this we've sort of figured out with the help of Nancy's modeling, that this is an oscillation going back between the thalamus and the cortex. Remember, the thalamus is a very central part of the brain, very important for transmitting all sorts of information, pain information, auditory information, visual information. If you were to tie up the frontal cortex and the thalamus, you can understand why you'd be unconscious. But it looks something like that. Right? And we have very good experimental data, both in rodents as well as non-human primates, to support what we first figured out with modeling. What I want to talk to you about are these slow oscillations. Look at these guys here. So they're just as strong, they're just as strong as the alpha oscillation. And they're doing something entirely different. So that's what I want to just give you a hint about right now. So these are some of the best data that I have showing you what anesthesia does in the human brain. So these are patients that are having epilepsy surgery. So they come, they get electrodes implanted, and they stay in the hospital for 5 to 7 days until the care team figures out where the epileptic foci are. So they're off medications for 5 to 7 days. They seize, and once they figured out where the seizure foci are, they come back to the operating room to have the electrodes removed. Then in a separate visit, they'll have the resection. So these are the grids and the microelectrodes that are used. And this is an illustration here with this. So these traces here are being recorded at these sites here on the medial temporal lobe. And so this is a neuron which is next to this red electrode here, which is spiking. So you can see the person is conscious, the neuron is spiking pretty much wherever it wants to. Now, same person when they're unconscious now under propofol, and look, you have the large slow oscillations. Look what the neurons are doing. The neurons can only spike now, spike now, spike now. So every about 2 seconds or so. So you've got this very low frequency oscillation. So it's tightly correlated, perhaps even modulating when the neurons can spike. And so I can't tell you how slow it has to be for you to stop, become unconscious, but I would submit this is going to be very difficult if a neuron here is basically spiking now, and this one over here needs to spike at the same time, or this needs to spike, sort of in a related time period to transmit information. It's going to be very hard to do. But I can show you a little bit better data on it now in our non-human primates. This is work which we've just published. It actually was published last year in eLife. And this is Earl Miller, my colleague at MIT, and also Jake Donahue, who's a MD PhD student. This is from his PhD thesis. So here's the animal awake. This is a non-human primate. So 4 areas. So these are frontal areas. So 8A, the frontal eye fields, PFC, prefrontal cortex, posterior parietal cortex, and the superior temporal gyrus. So you've got 2 areas here. You've got 2 areas back here, right? And you can see the just sort of low amplitude oscillations like we saw in the woman in the video, in the EEG video. And then here are the neurons spiking. The neurons are spiking pretty much wherever they want to. And just to give you some feel for this, this is about 10 spikes per second. All right. Now over here, look what happens. Here are the large slow oscillations, just like I showed you in the human data. Large slow oscillations. And look what you see now. Just so you have these up-down states. So when you have a down state, it's almost coherent across the entire cortex. And then you can see there's much less spiking. This is 10 spikes per second. This is a half to 1 spike per second. So if this is consciousness, this is certainly unconsciousness. And I can't, like I said, I can't tell you what the rate has to drop down to before you become unconscious, but this is certainly unconsciousness. Now, why am I harping on this so much? Because I get calls all the time from reporters who want to write articles about anesthesia. And they're like, can you tell us about one of those cases where someone was awake and you didn't know it? I'm like, dude, no. I mean, you know, that's kind of like not cool, right? You know, but that's what people think is, you know, and being aware of anesthesia is not a public health menace. It happens 1 in 20,000, 1 in 10,000 times, right? But the reason it can happen is, well, I said I use the EEG in my practice all the time. Most anesthesiologists don't. In fact, only about 25% of them really do. And so if anything I've suggested is remotely correct, slow oscillations mean exactly what or something approximating what I just said. If you said this, or the alpha oscillation mean exactly what I said. If someone came to me and said, you know, Emery, the last time I had anesthesia, I had awareness, right? And you know, I'm afraid. I said, well, look, don't worry about it. It's not going to happen. I'd, you know, put on the EEG, dial them down until I got a state like this. And I'd be very confident that they're going to be unconscious. So that, I mean, that's the practical benefit of this. And so this is what I've just shown you, basically. With the alpha oscillations, we think it's coupling the thalamus and cortex together, sort of tying them up. The slow waves creating these very large up-down states. I showed you this anteriorization. And the anteriorization, what you actually saw was, once the anteriorizations happen, you know, the forward movement, that alpha oscillation, the posterior dynamics across the posterior aspects of the brain are different from the anterior aspects. You've got a whole nother phenomenon which is helping to make you unconscious, if you would. So you've got at least 3 things here. There are probably a lot more. These are just the ones that are sort of easy to measure. Plus, there's inactivation of brainstem pathways, which I could show you clinically. So there's several things that are occurring to make the person unconscious. So if you take away nothing else from this lecture today, general anesthesia is not sleep. All right? So, and this is important because anesthesiologists, we often walk up to the patient and go, you know, Mr. Jones, I'm going to have you go off to sleep for your surgery today. I mean, we can't walk up to them and go, Mr. Jones, I'm going to put you in a drug-induced reversible coma. Don't worry, I know how to wake you up, right? You're going to, you know, just jump off the table and run out of the room, right? But what I do is actually just tell the patients exactly what's going to happen. You're going to be unconscious. You won't feel any pain. You won't remember anything that's going on. We'll give you medications to make sure that, you know, you're totally comfortable, and also that, you know, we're watching your physiology. I give them the definition of general anesthesia. This is general anesthesia, and so physiologically, it's actually quite different. So this is just frontal alpha. There's that posterior alpha that I showed you, the eyes closed alpha. So we bring you down and we hold you to a state like here, like this, and the brain is doing this basically. That's the brain oscillating under anesthesia. With sleep, as you know, what you do is you start off with non-REM stage 1, go to stage 2, stage 3, slow wave sleep, and back up to REM. You do that about 4 to 6 times a night, roughly about every 90 minutes or so. Totally different dynamic, basically, from anesthesia. Even though these slow waves might look something like this, there's a totally different sort of physiology leading to these dynamics compared to anesthesia. And just to take it a step further, if you think about current sleeping medications, if instead of calling them sleeping medications, you call them weak anesthetics, that's actually what they are, because they're also in the same drug class, many of them, as the anesthetics. They work on GABA receptors. So what they do is they sedate you, and then the hope is that your sleeping mechanisms take over. But if you think about it, no sleeping drug can make you go REM, non-REM, REM, non-REM. That's not possible, right? So it's very misleading what the actual as far as what sleeping medications are doing. And so the fact that people don't have restful sleep after sleeping medications it makes a lot of sense. But general anesthesia is not sleep. And so I've shown you a lot about propofol here. And if you look at these signatures in the time domain, maybe they look different. But if you look at their spectral content, you see they look quite different from a spectral standpoint. And that's why in the operating room, we use both the broadlight signal as well as the spectrogram to track what's going on. And here's ketamine. I just want to mention ketamine, because what's kind of cool about ketamine is that you saw the propofol produce part of its dynamic by actually slowing things down and making the neurons spike very, very rarely. With ketamine, the spike rates are just the same as they are when the person's awake. But what it does is it gets very fast, even faster than what it was at baseline, these sort of gamma oscillations. And this is someone who's sedated on ketamine. So this is the ketamine dose where people get high on, basically, that they take on the street, so, for example. Or ketamine is being used now to treat depression. So this is the same sort of thing. This would be a dose where someone would treat depression because at this state, they have the hallucinations or the out-of-body experiences. When you give them a dose which is large enough to produce anesthesia by itself, you get the fast oscillation and slow. It goes fast and slow every about 4 to 10 seconds or so. So it's a whole different dynamic, completely different from propofol, but they're still unconscious. So becoming unconscious is not just one pathway. It's any pathway that sort of moves you away from the dynamic that's in the conscious state, whatever that dynamic is. As long as you move them somewhere far enough away, it's possible to generate unconsciousness. And we are talking about, so for example, dexmedetomidine. This drug here probably most closely approximates sleep of all the drugs that we have. The way it acts on the brain is closest to the way slow wave sleep starts. So this one, and now there's an oral form of this medication, which is being tested as a sleeping medication. And so we could do a deep dive into the circuits the same way that we did with the propofol here. Yeah, exactly. In other words, so let me just say it this way: it's totally correlative. In other words, in terms of whether it's whether the part which is most tightly coupled is the slow oscillations. When the slow oscillations come on, there's a strong correlation between the appearance of the slow oscillations and the slowing of the spiking activity. And so I'm just speaking electrophysiologically now about the alpha oscillations. There's an alpha oscillation going back and forth between the thalamus and cortex under propofol anesthesia. And that frequency band, the normal frequency band is here, that frequency band is here. And that's just going to be very difficult to communicate. So whether it's the tight correlation, let me just say it that way. Very tight. Other questions?
Normally take for the patient to come out of anesthesia after you turn off the drugs?
That's a good question. So that's the art of the anesthesia, where you the surgeon's finishing up, they're putting the last stitches, you're turning down the propofol, you're turning down the gases, and you try to time it so that as soon as they finish, the person comes to. And it can be sometimes as long as 30, 20, like a minute or so, maybe even several minutes or maybe a half hour, depending on how well you timed it. And that's one of the reasons why, if you're not using the EEG, you don't really know what the person's brain is, essentially. And that's what I'm going to show you in just a second here, that one of the things we want to do is turn the brain back on. Because what happens is that those oscillations, even though you've turned off the drugs, there's still persistence of them, basically. They don't just dissipate as soon as the drugs stop. And that's why you have one of the reasons why you have the delayed wake-ups. Delayed wake-ups. Okay, so I'll push on. So just, again, my colleagues did this with. So our colleagues from Children's Hospital in Boston, Laura Corneliuson and Chuck Birdie, Shuna Keiju, who's now our new chair of anesthesia at Mass General Hospital. Chung-Eun Kim is one of my postdocs, who's now assistant professor back in Korea, and Patrick, I mentioned a second ago. So let me show you what happens with age. So this is a 30-year-old on propofol. Alpha oscillations, slow delta oscillations, what we've talked about already. That's old news. But here's someone who's 57 on propofol also. Same pattern, maybe the oscillation is a little bit weaker. It's shifted down in frequency a little bit. It goes from about 8 to 12 here. This is a little bit higher, maybe about 10 to about 15 or so. But the slow oscillation and delta oscillation are pretty strong. This is a woman who's 81 years old, right? She had a tumor on her chest the size of an American football. It took the thoracic surgeons the better part of 6 hours to remove it. And you can barely see alpha oscillations here. But she has these very, very weak slow oscillations. So to take care of her, because I was using the EEG, I gave her 1/3 of the already age-adjusted dose of the drugs. And I was able to wake her up on a dime. And I wake her up immediately because I was watching the oscillations and I knew exactly where she was from a state of unconsciousness, essentially. The benefits of using the EEG. Now, this next thing is a little bit sobering. So these two guys are roughly the same age. His EEG looks like his EEG looks like hers. And it's a little bit surprising at first when you go, well, we age different physically. It makes sense maybe our brains age differently, depending on how well or how poorly you've been treating yourself. And so the fact that we see this all the time now, apparently older brains in sort of younger people, or even vice versa, much younger brains than some people who are more aged. And so there's some hint that anesthesia can tell us something about this. And if you think about it from a neuroscience standpoint, what you're doing is you're putting in a stimulus, and you're seeing how the circuits oscillate, essentially. And for a nice healthy brain, it oscillates like this or like this. As it gets older, it oscillates like this. And so, like in this case here, remember, we don't have to invoke anything about Alzheimer's or specific neurodegenerative diseases, but just think of a neuron. A neuron's been around for 81 years. The myelin sheath breaks down. The dendrites don't extend and retract as much. They don't produce as much neurotransmitter. The cytoplasm declines. The cell is more susceptible to oxidative injury. And so this neuron here has been transmitting signals for 81 years compared to these, which are much younger. So this is just a normal process of aging. And as predicted, you can use less anesthesia with older patients, but we can use actually substantially less than I think most anesthesiologists realize. So you can guess what the kids look like. So there's a 3-year-old, and there's a 14-year-old, right? So you have the same dynamics across age, but the frequency bands, are much broader in the younger kids. And in fact, I think I have it in here. I don't have it in here. The power is actually the highest. The total power is actually the highest, like right in here, between 6 to 8 years of age, and then it basically declines. The total power basically with age. So you have a different strategy for monitoring than you have, compared to the 81-year-old. And many of the manufacturers of these indices to track brain states under anesthesia could not understand why they didn't work on kids. They would build, and I know this seems very hard to believe, but you can just go check the literature, look up the BIS monitor. And again, because this is something you guys are expert at thinking about, these sort of machine algorithms. So they built the algorithms based on people here, and then they're surprised when it didn't work on kids. They never really looked at the data. So you can have an algorithm that will work on kids, but clearly it has different spectral properties. It's really obvious when you display the data like this. Question?
Sorry, is it clear then at the level of the circuit what is actually going on there?
I'm sorry.
I'm here.
Oh.
Sorry. So in the old brain, let's say, is it known what is actually going on in terms of circuitry and why you don't see any more that oscillation specifically?
Yeah, so I think in the experimental sense that you mean we don't know as much as we should, but I think we can make a reasonable conjecture. I mean, and I think what I was saying about her wiring, her wiring is 81 years old. And so, like I was saying, the neurons, basically, they're losing their myelin. They're not conducting the currences as faithfully as they would when she was younger. Anyway, then patients who have neurodegenerative Thanks. Patients who have neurodegenerative disorders, they certainly have quite diminished EEGs also. So the fact that some sort of pathology or aging would be associated with a change in EEG seems very plausible. Question here?
Yeah, I was wondering, you mentioned that for the older brain you would need less anesthesia.
Mm-hmm.
Does that mean kids need the most?
You do in a sense, yeah. If you look at the concentrations that are given to kids, it's higher relative to what the older patients are getting, yeah. Very much so. If they did it based on the neurophysiology of the brain, the kids who would need the most are the kids who are between 0 to 3 months of age, because their circuits haven't formed as well. And something happens at 4 months. It's really amazing. There's a much larger, there's a dramatic change in the EEG. And then you start to have, they probably need a bit more. So the doses, which the protocol, what they call the MAC doses, sort of the minimal alveolar concentrations for the kids, higher than it is for the adults.
And you can see those differences as well when they're not anesthetized?
That I don't know. Because remember, what I'm doing here is I'm amplifying everything by doing this. But now people are going back and looking for these now. They're looking for this sort of patterns to see if they can see who ahead of time might have an even weaker brain than someone might conjecture for their particular age. So now that they've seen this under anesthesia, they're going back and see, well, could we have seen it in baseline, known that a priori and done something different? I would do something different anyway. It's got to be there. I mean, why waste the time? Just use the careful techniques right from the start. It's a moot point. That's what I do in my practice. I think there was another question back here.
I was just going to ask, for the old brain, is there anything in the past medical that predicts this? Like any lifestyle choices or any comorbidities or anything like that?
I've seen some. I'll tell you about two. So one is a drug addict, right? 34 years old, who came and had been shooting up, got this necrotizing infection across his whole arm. And he was in the ICU, and every 3 or 4 days he had to come down to the operating room to have the dressing changed. And I asked the nurses, how asleep is he? How sedated is he? And they said, well, we don't know. We're not using the EEG. So I was dying to get him down to the OR to see what his EEG would look like. When I put the EEG on him, he's 34 now. He looked like that. He looked just slow oscillations. That's all he had, right? And I thought the machine wasn't working, right? Then I come to find out that patients who have rip-roaring inflammation, that's what their EEGs look like. And that's what the EEGs of like the COVID patients look like. And literally just this past week, the first time I got to see the reverse, we had a gentleman we took care of in the ICU for several weeks who had COVID. His EEG looked like this, right? And then just last week, towards the end of the week, when his lungs cleared up and everything, the inflammation was gone, his alpha oscillations came back. So and that's the first time I conjectured that would be the case, but I hadn't seen it literally until this week or so. Another case where it also happens is in patients that receive chemotherapy. Chemotherapy just does a number on the brain. And we had taken care of like some very young patients that had chemotherapy. Their brains look like these down here under anesthesia. So the anesthesia is actually showing you some effects of health as well as, some pathologies as well. Yeah.
Hey. Can you use different anesthetic agents? Or do they work differently based on the spectrogram? As in, can you basically predict that, for example, ketamine might be a better agent to use than a benzo, given that their profile looks a certain way?
Yeah. So I think that I can use them more effectively knowing how they work, knowing their mechanisms. I certainly can. I do that. And one of the things, I'm not going to talk about it in this lecture here, but one of the things I do is to control the pain of patients under anesthesia, I don't just use opioids. I actually use 3 drugs. And knowing how they work, each one attacks a different pathway. And what that does is that gives me much better control of pain, but it also decreases arousal, which means I can use less propofol in order to keep the patient, unconscious. So knowing the mechanisms of how the drugs work by, taking these diagrams seriously and doing this work here, we can dose the drugs differently. At least I do anyway.
What about using the pre-anesthetic spectrogram to predict what agent might be more effective in the patient? Because you've already used an agent, and if you see it isn't working, then you need to switch to something else, but it's still in their system. So you kind of run the risk of side effects with another agent cumulatively add.
So our options for different drugs are actually a lot more limited than you might imagine. So propofol pretty much starts every case, and then maintenance is with propofol or sevoflurane, basically. So there's not a lot of flexibility there, as your question suggests. And if I were to, so I could do a whole case with just ketamine. I could just use high-dose ketamine and have someone be profoundly unconscious, and they would have analgesia as well. In fact, that's one of the reasons why ketamine is considered an essential drug by the World Health Organization. Because if you have to go to some remote area to give anesthesia care, and you can only take one drug with you, you would take ketamine. What's going to happen is they're going to have potent analgesia. They'll wake up very comfortable. They're going to wake up very sluggishly. It may take them an hour and a half to sort of come to. In addition, they're going to be hallucinating like crazy, right? So even though it's effective as an alternative, the side effects in that case would be much more substantial. And this is one of the problems in anesthesia right now. We haven't had a new drug in 30 years. So, I mean, it's just like everybody feels that what we're doing works well enough, so they're like, why mess with it? No one wants to put in the energy to sort of sort out some new approaches or new ideas. So those are the kids. So let me just tell you finally about the closed loop control. So you've probably heard about the term medical coma. I didn't put the slide in here, but very often when people get a head injury or they have intractable seizures, they're placed in what's called a medical coma. And a medical coma, all it is I'll just bring it up here. You just give a person a high dose of like propofol or one of the other agents, and you take them down to the state here in burst suppression. You hold them there for several days and maybe several weeks. Remember, Michael Schumacher, the racing driver, had a very traumatic head injury, and he was in a medical coma for a month or more. And something like this has been happening with COVID patients, but it wasn't intended to be a medical coma. The medical coma is really intended to really turn down brain metabolism dramatically in order to allow the brain either swelling to resolve or for the seizures to resolve, right? So if you know you're going to be in a state like this for several days, why not build a controller to basically control the system? Very straightforward. And the pattern of burst suppression is easy to see. You saw the patient go into it in the first video. And so I can easily define the state of burst suppression by just, if I had a 1 second window, I talk about the fraction of time the patient is suppressed, like here, 0.4, relative to the remaining time where there's actual normal activity. And that ratio would be like 0.4 in this case. So what I could do is I can easily define the concept of being in burst suppression. That's the point. I mean, it's something I can easily track, and as I dose the drug, essentially try to control it. So this is a model we use. So this is old now. This is 9 years old, essentially, where you're measuring EEG in real time, and you set a target level of burst suppression. This is a very standard sort of feedback control system. You have a target level of burst suppression, then you have what you actually measure. Take the difference, it changes the infusion rate, and you just do that in real time. You update every 5 to 10 seconds or so. I'll just show you what this looks like in this video. So Miriam Shinichi did this back in 2013. So when you start, so the top panel up there, that's the EEG, and the green line is the target. That's what we're trying to hit. So the white line is what the target is actually hitting, what it's actually doing. But it's actually holding it pretty well. It's a little bit below, perhaps, and the axis is in minutes. And the lower panel is actually the infusion rate. So now Miriam tells it to go up to 0.7, so it jumps up, it gets up there by changing the infusion rate dramatically. Now it's really holding on to 0.7. So 70% of the time, the EEG is suppressed, basically. And now she's going to take it up to 0.9 to suppress it even further. So to 0.9. So this is totally feasible, and this is just using sort of basic sort of feedback control systems with an elementary pharmacokinetics model like for this system. And so if you look at this, I showed you this one up here. See where it's going up, going up, going up. But if you want to come down, so you can go up. When you come down, to get down, I don't have a drug that can decrease burst suppression. So what it does is the pump shuts off. The pump shuts off. The system glides back down to the state here, and then it picks up again and reestablishes the control. So totally feasible. So we had this 9 years ago. And the FDA said, well, that's all cool and everything, but that's not good enough to let you start testing this in humans. You have to do experiments on larger animals. So in the last few years, we set up a system for non-human primates. This is Suresh Chakrabarty, one of my former postdocs. We did this work with Matt Wilson. With Earl Miller. So the same idea. You have some sort of marker of unconsciousness that you're tracking, and then you can basically read it in real time, compute it in real time, use a controller to basically change the infusion rate of the pump, in this case every 20 seconds. And I just want to add a little bit of neurophysiology to it. We were talking about the spike rates. The spike rates went down dramatically when the animal was unconscious under propofol. And so the power in the 20 to 30 hertz band tracks that. So this you can measure in the EEG. So if this is happening when the EEG is doing this, so by measuring this and controlling this, I'm controlling the state here essentially. So we're going to use this as our marker basically, power in the 20 to 30 hertz band. And just to show you this, Suresh normalized this so the number should be about 1, should be about right here. And then this is the infusion rate here, and this is the error, and the spectrogram will be down below. And what he's going to do at first is he's going to just leave it open loop. It's going to be a constant infusion rate running with the propofol. And then it's going to take over control. Because we want to simulate what happens in the operating room. Because in the operating room, we don't have control systems. So it's just the pump is running constantly. So you see the constant infusion rate. You see how the marker is moving all over creation. In fact, it's going to go down below the line, getting deeper and deeper. Now the controller takes over, brings it back up, holds it right at 1, right where it should be. And then we're going to take it to, let's see, I think it goes a little deeper, yeah. So now it jumps down to a lower number is basically a deeper state of anesthesia. And now he's going to take it to an even lighter level, about 1.1 as opposed to 1. So it jumps up to about 1.1. Right? But the thing I want to point out here is, look at this part right here. Look right here. This is the OR. We run constant infusion rates all the time, and patients just get deeper and deeper and deeper. That's the reality. The first thing the controller did when it took over, it actually turned the pump off for 2 to 3 minutes to let the person get to the level, the animal get to the level where it was supposed to be. And over here, the same thing. To get back to the level where it needed to be, it actually shut down for 8 minutes or so, right? So you can see that we're grossly overdosing patients basically in the operating room. And this is a very simple controller which could easily be applied. So now that we've done this, we're looking to get FDA approval to do this in humans. I'll just leave you with one final idea: reanimation. We were talking about what determines whether someone comes back. Like, I don't give them the drugs to wake them up, right? But that's what Ken is working on here. He's going to do it electrophysiologically here. So this is a rat that's anesthetized with propofol. And what he's going to do is, I'll just play the video. He's going to stimulate his ventral tegmental area. This is equivalent to giving like Ritalin. So Ken's done as a Ritalin as well with VTA stimulation. So he has IV in his tail vein, and this is the propofol. Propofol is white. It's running into his tail vein there. And watch right here when he turns on the microstimulation. Watch his breathing right there. You turn on the stimulation. So it's breathing like crazy. The propofol is not turned off. He gets up and says, Ken, I'm out of here. I'm leaving. All right. All right, so he runs off, right? But is he conscious? Is he able to process? So Ken did another set of experiments where he trained the animal to execute a task. So it hits a light, and it hits the correct light, he gets a reward. Hits a light, gets a reward. All right. Now he's going to anesthetize it with sevoflurane this time. Right. Then he's going to stimulate his brain to wake him up again. He's going to wake up. He's going to realize, oh, I'm in that work chamber. He's going to go back to work. The anesthesia is not going to be turned off. And then what he's going to do is he's going to let him work for several minutes. Then he's going to turn the stimulation off, and the animal's going to go out. Let me just show you this. So he's out there. He's anesthetized with isoflurane. He's in one of these sort of anesthesia chambers. No stimulation. So he's going to stimulate the ventral tegmental area to wake him up. Turns the stimulation on. He comes to. He looks for a reward first, but there's no free lunch. You got to work. All right. So he turns around. He hits the correct light. So that's the light he has to hit. Hits it. So he gets a reward. Right. So it's showing he's actually processing cognitively. The anesthesia is not turned off. It's still going. All right. It's that he's wobbly, right? But he's still functioning. I think he gets the next one wrong. Let's see. He turns around again. Turns around. So that's the wrong one. So he didn't get a reward that time. So now it's going to happen. He's going to turn around to start working this one last time. And Ken turns the simulation off, so he's back out. He's unconscious now, right? So this is one of the things that we want to start studying is, can we actually control brain states precisely? You know, however we want them, turn them on, turn them off. And this is suggested, it's some measure this is possible.
Just two things. What was the rationale for selecting the VTA as a stimulation site? And the second thing is, how does the performance compare when you're stimulating the rat versus when the rat isn't sedated doing the task?
Okay, so if you stimulate, all right, so let me answer the first question first. That was the first question first. So here, let me just go back to. So this pathway here, so this is the mesocortical pathway. You know, we normally think about it for reward, but it's also important for cognition, right? And we know that because when people take Ritalin, they self-administer Ritalin, or we give Ritalin to kids with ADHD, we're actually taking advantage of this pathway. So we wanted to activate a cognitive pathway, not just an arousal pathway. So this is arousal, cognition, as well as rewards. That was one of the reasons why we chose the VTA. And if you stimulate the VTA while this animal is awake, it's like giving him a shot of Ritalin. I mean, he'll get super hyper. It does exactly what you might imagine. But so this is sort of the neurophys of what we're doing. Stimulating here, giving Ritalin, you know, you're increasing the reuptake of dopamine. You're blocking the reuptake, I should say. And so this is why the animal would wake up. And what I showed you was doing it electrically, but we've also done it optogenetically, getting specifically at the D1 neurons. So this is what I've just shown you. So we think that one of the mechanisms in which the drugs are working through these oscillations, showing you that, and the oscillations change very dramatically with the different drugs. It's a way for monitoring the state of the brain and also for controlling it. And I think that turning the brain back on is something which we should really be doing, because for an older patient, 40 to 60% of older patients, older doesn't have to be, over 65, it can be just, 50 or so, have some sort of brain dysfunction after anesthesia. And especially, just think about it, your brain is doing this for 3 or 4 hours under surgery. It makes sense that it's not going to just pop back. But these ideas of reanimation, I think, would help us reduce this problem of cognitive dysfunction. And I've learned a lot about the brain by trying to take the brain seriously from a neuroscience standpoint. And that's not the perspective that most anesthesia research follows. It's really based on pharmacology, sort of drug design, and not as much on trying to understand brain circuits and actually attacking or controlling specific brain circuits. So our ultimate goal is to try to control these circuits, as precisely as possible to create whatever states of arousal or that we'd like to have. So this is like, you've seen the New Yorker's version of the United States, where there's New York and there's the rest of the country sort of depended on. This is anesthesia for the anesthesiologist. You know, we're here in the middle, and the rest of clinical neuroscience like rotates around us, basically. But this is true. I mean, there's so many connections between anesthesia and all these various problems in neuroscience we just don't take advantage of. You know about depression, but what I just showed you just as one additional example. Depression and ketamine, let's say. Ketamine is also used to treat pain. It's used to model schizophrenia. But with coma recovery, the paradigm that I showed you that Ken is using, giving Ritalin to the rats to wake up from anesthesia, we now have a clinical trial ongoing in our neuro ICU. Use it as a way to try to wake patients up from traumatic coma. So blending these ideas can help us not only improve, using neuroscience can help us not only improve how we do anesthesia, but also draw from clinical neuroscience and also maybe make some contributions to help solve some problems in clinical neuroscience. So I'll just stop there. Thanks, guys. Question?
Hello. Oh, thank you. Two questions. The first is about the microstimulation.
Mm-hmm.
There aren't numbers of passage or some other, volume conduction effect that anesthesia and it's.
So the best evidence I have for it is like when we cell-specific stimulation, like we do specifically the D1 neurons. So we do specifically the D1 neurons. So there, we know that that's just activating the dopaminergic neurons in the pathway. That's our best evidence here.
Oh, so you've done optogenetic stim?
Yeah, that was on the slide, optogenetic. We've published that too.
Oh, okay, I see.
Optogenetic stimulation, so we've done that.
Okay. So the second question is about other catecholinergic structures in the deep brain. So can you do this with LC or with any other one?
Well, see, this is what's really interesting, and something I've learned from thinking about the brainstem, essentially. So we have all these neurotransmitter systems in the brainstem. So locus coeruleus, norepinephrine, serotonin, dorsal raphe, parabrachial nucleus, glutamate, or what have you. Or you have something really, or like the tuberomamalar nucleus, which releases histamine, or like lateral hypothalamus, which releases orexin, right? They're not all created equally. Like, just to give you an example, we know that the tuberomamalar nucleus is very weak, right? Because histamine and antihistamines are not anesthetics, right? They make you a little drowsy, but they're not anesthetics. So you have to pick your pathway in an informed way. And so one of the things, so the cholinergic pathways, if you activate the cholinergic pathways, they are powerful. The rat basically just jumps off the table, essentially. And also, if the animal is profoundly anesthetized, like in burst suppression, it won't work. Everything is too turned off, essentially. And a big surprise to us that we just saw, we learned in the last year or so, is that the parabrachial nucleus, which is a very potent glutamatergic pathway coming out of the brainstem in the pons there. Stimulate it, nothing happens. And other people have found this result also. So you have to pick your pathway carefully. Question?
Okay. So you had a slide comparing patient under GA and the sleep. It's like a chart side by side. Do you mind going back there?
Yeah, sure.
Thanks. So I think if I remember correctly, you said the biggest difference, obviously, in sleep, they go through these REM and non-REM phases.
Right.
But could you elaborate more on the differences and maybe even the similarities between the two states?
Yeah, so there are very few similarities at all, really. I mean, and again, it's just because the state that patients know of and you think they don't feel frightened of is sleep. So if you say, I'm going to have you go to sleep, that's why we say that. But we shouldn't do that. We should say you're going to be under general anesthesia. You're going to be unconscious, basically. But if you look right here, so remember, you start here and you come down into non-REM sleep. Then you have this slow wave sleep. So this is when the brain is most turned off. And if you look at the state of the muscles, so at that point in time, you have like this sort of most muscle tone. This This is actually when you sleepwalk. You typically sleepwalk during slow wave sleep. And the other thing too is if I went to someone who's in slow wave sleep and I go to shake them like this, they'll come too. They'll wake up, right? Then you go back up here to the REM state. Remember the REM state, what we're learning now, like with, like our hippocampal experts, they're telling us that there's a lot of work going on where things are being pruned, information, synapses are being reinforced. And the other thing is that it's a very much an awake state. It's a high cholinergic state. In fact, you get there by releasing a lot of acetylcholine from the lateral dorsal tegmental tract and dorsal pendine tegmental tract. So you're basically awake, because a lot of times right around REM sleep times, you'll see microarousals, essentially. While all that's going on, going through these different levels of arousal where you could be woken up if someone shook you. In contrast, right here, this is propofol. You're sitting there. Your slow waves are making your cortex, your cortical neurons fire every 2 to 4 seconds or something like that. Spiking rates have dropped by 95% essentially. The thalamus and cortex are tied up in an alpha oscillation. So the neurophysiology of these states is so different. There's really no comparison between them. And again, the closest thing that you get to is maybe here, the sedative state, where someone's arousable, but what's happening there is, well, let me just say it this way. Remember, sleep actually happens, it comes on by turning the brain off from the bottom. In other words, you actually turn off the arousal centers by the preoptic area of the hypothalamus, activating the inhibitory pathways and sort of turning the brain off from the bottom. The anesthetic drugs like propofol, they're acting in the cortex, the thalamus, they're mucking up everything. So it's a totally different set of dynamics altogether. It's nothing like sleep whatsoever.
Okay, so how come so you're saying even in stage 2 and 3, obviously if you shake the person, they can wake up.
Yeah.
Why? What's the mechanism for that?
Of them waking up?
Yeah.
Oh. That's straightforward. What happens is, if I pinch you right here, right? Basically, that nociceptive information actually travels through your spinal cord, goes to the projection neuron, goes into the arousal centers in the pons and the medulla, on up to the thalamus and cortex, goes to the nucleus tractus solitarius, increases your heart rate, what have you. In other words, you're actually activating autonomic nervous system as well as motor pathways, in addition to sensory pathways. That's why you come to. And if you're profoundly asleep, you have to pinch a little bit harder, but those pathways are still basically intact. Under anesthesia, they're blocked. Okay. Right? Especially if I give you drugs to control pain, they're totally blocked. That information can't get through.
Okay, so these pathways eventually hippocampus and thalamus region, and it stops doing the thing that induces sleep. Is that what you mean?
I'm sorry, in what case?
I can ask you afterwards, so I can let other people ask questions.
But I guess the main thing to understand is this right here. The best way to think about this is pathologic. This is not natural.
Right, I understand that.
Okay, exactly.
Yeah, thanks.
Yeah.
That was very clear. Thank you.
Mm-hmm.
What's the mechanism behind burst suppression? And why do you get that pattern?
Oh, that's a cool question. So we wrote a paper about this in 2012, and we've gotten more interested in it recently because of COVID. So what we think is happening is the brain is at a metabolic precipice where there's a decreased amount of ATP. All right, and so remember, you need ATP in order to keep your sodium and potassium channels functioning, across the neurons. So what happens is if you have a dearth of ATP, then what happens is you get a potassium leak current. The channels open, and the spiking activity, the field potential activity becomes depressed, and it's turned off essentially. And that's what happens during the suppression period. And during this time here, the ATP is building back up. Once it builds back up enough, the channels can close, and you get the bursting activity, but it uses it up again. and it comes back. So that's that was a model that we theorized back in 2012 and published in PNAS. And since we've actually done experiments that actually sort of support that idea that this is probably it turns out the anesthetics have a neurophysiologic effect on neurons. They also have a metabolic effect. And part of it looks like they probably inactivate the mitochondria as well. So at high enough doses, that's why this occurs at high doses just with the GABAergic anesthetics. That's our conjecture.
I was wondering, some of these oscillations, gamma, theta, they are also seem to have some sort of hole during the awake stage of animals, for example, in the processing of information, visual information with gamma and theta with memory.
Right.
And I was wondering, how is the intersection between these oscillations that you're talking about, where we seem to have the absence of function, like we're not processing information anymore, you're not forming memories anymore, and these are the ones that are supposed to process information during awake states.
Well, that's a good question. So like, for example, that would be awake right there, like with the gamma, essentially, right? And so we talked about this a little bit in our 2013 paper, where I've been putting the emphasis on these guys here, like the slow oscillation and like the alpha and slow oscillations, right? Because all of a sudden, the predominant thing you see is you go from the gamma or the maybe high beta into those states. It turns out, and this is in our 2013 paper in PNAS, that the gamma oscillations actually go up too. But these have gone up so much more, they're actually dominating essentially. So basically all the power kind of went up. But these lower frequency oscillations, their power went up dramatically more than the gamma oscillations. And so, Nancy Coppell has written a lot about how these are important for forming these cell assemblies that allow communication among different parts of the brain. That's why we think is one of the primary mechanisms in which the drugs are impairing communication, because you're moving out of the brain, one of the brain's normal communication modes, essentially. That's our conjecture. Other questions?
Is the recovery from anesthesia with children is better or worse comparing to adults?
Oh, that's a good question. So, kids, 25% of kids who get like the inhaled drugs like sevoflurane wake up delirious. I mean, and like just this like flailing around and what have you, and it freaks the parents out like crazy. And this is one of the reasons why we're trying to work on ways to help wake. I talked about the older patients and brain dysfunction, but the kids are actually another case we're also very concerned about, because they'll wake up delirious, and the parents like look at you like, what did you do to my kid? What's going on here? And right now, it's ironic, but do you know what the solution is the anesthesiologists use? They re-anesthetize them. So they'll re-anesthetize with dexmedetomidine and allow them a longer period to wake up with the dexmedetomidine as opposed to like the sevoflurane. So what we should do is actually push them through that period and push them awake. They're just not completely awake. In fact, this is a bit of hand waving, but we talk about the brain developing frontal control. What you're probably seeing is that frontal control just basically was so disrupted. Lack of frontal control was so disrupted, or it was taken advantage of basically by the anesthetic, that they don't have the sort of mechanism that older patients have to sort of regain control much more quickly. So having something like Ritalin which might help that would be certainly worth testing. But kids will wake up, they'll go and they'll be flailing around and what have you, even as old as like teenagers, that sort of thing. So it can be a real problem. And the solution is just the opposite. The active solution right now is the opposite of what you would predict it should be. I'm sorry?
The other 75% of the kids are waking up okay?
Yeah, but the other thing too is, I don't think it's okay. If you ask me my personal opinion, I don't think it's okay. Why should you be sleepy when you wake up from anesthesia? Why shouldn't you just wake up and just, if we're having a conversation beforehand, why shouldn't your brain just be clear and just, and it's because there's still residual. So if the person wakes up and is just sort of lying there, like snoring like crazy, oh, beautiful wake up, right? But you can't talk to him. The guy's out cold. I mean, you should wake up, start talking again. Yeah, how was the Mets won last night? Yeah, that's great. Fantastic. you know. But that's not the state of affairs at the moment. But that's what I'm after, essentially. And I think that's possible with some of these ideas of turning the brain back on and having better control of the dosing of the drugs during anesthesia. And also, if we're dosing it in a way that reflects the neuroanatomy, neurophysiology, that's also going to make it better. So I'm after the perfect anesthetic.
So you mentioned earlier that sort of current practice as an anesthesiology is such that some people don't use, well, the majority of people don't use EEG states to titrate their anesthesia.
Mm-hmm.
Have you noticed, maybe anecdotally or in a head-to-head trial, the actual clinical consequence or effect, I guess, of using EEG sort of derived titrating of anesthetic agents versus whatever other metric is used?
Well, that's a great question, because what's happened is that in the trials where it's been tested head to head, it shows no improvement. No improvement. In other words, you don't gain by using EEG. That's what the trials say. And then what happens is, what you have to realize is, the trials were set up in such a way that people weren't really trained to use the EEG. They're using just a marker. They're not reading the EEG. And in fact, in one of the trials, the one which was about 3 years ago, the Engages trial. So we have on our website, and supported by the IRS, we have education programs. And so to make it appear like they had trained their anesthesiologists to use the EEG, they said, oh, we told them to take, the course that's on the Brown website, sort of thing. So that was training. So in other words, if it failed, it was our fault, right? Because we didn't train them properly enough. Yeah. Oh, makes a huge difference. Come to my OR.
In what? As in what exactly? What do you see?
Exactly what I was talking about here. I was talking about how the people wake up. So I have better control of pain. The people wake up as soon as the case is done, and we engage again and have a conversation. But to do that, you have to pay attention during the whole case to the EEG and really fine-tune the drugs. People don't want to do that. They want to turn on the cerebral floor and, hey, how are the wife and kids? Oh, that's good. Yeah, good. Yeah, that's good. Yeah. You have to work. So, and they've got it down to an art. And if you turn the drugs off, and the guy's, oh, he's fine. Yeah, he's breathing. That's good. Yeah, let's get him out of here. Get the next case in here. See, it's not the anesthesiologist's problem anymore, because the person's breathing again, their vital signs are stable. But again, this idea of, like I was saying, the perfect anesthetic, where people, think of it as, let's think from a neuroscience standpoint. We just want to go in, inactivate certain parts of the brain, put the person in this state, and then once they're done, reactivate, put them back the way they were. That's what we're after. But that's not what most people do. In fact, very few people do that. But folks, and actually, it's actually more prevalent, this sort of practice that I'm talking about, it's actually more prevalent in Europe and South America than it is in the United States. We use the gases much more here. And in Europe and South America, and actually parts of Asia too, they use much more of the IV drugs. So they're much more adept at dialing and controlling them much more precisely.
Any long-term side effects of anesthesia?
That's a good question, because so a few years ago, there was a lot of concern about long-term side effects on kids having anesthesia. So the good news there is that, if the kid has to have an operation, it's just one operation. If they're young, 2 years of age, 1 year of age, something like that, go ahead and have the operation. Nothing bad's going to happen to their brains or what have you. There's good data that supports that from at least 2 large clinical trials. The part where it gets to be tricky is when you have kids that have to have multiple anesthetics. The problem is they're probably very sick too. They have to come, and so you have 2 things. You have the kid sick, you've got the surgery, and you've got the anesthesia. So is the anesthesia adding something extra there? Well, they have to have their therapy, right? So you have to give them the anesthesia. That's why the best way around that would be using like the techniques that I'm talking about in terms of how you dose the drugs and what have you, using the EEG, and also coming with alternative approaches. But in those cases, there's a strong confound between the illness of the patient, the repeated therapies, and the anesthesia that you can't sort of untangle, basically. You guys are, you must be anesthetized now, so. All right, great. Well, thank you.